Coming on to the cardiometabolic actions. Atypical antipsychotics that have high metabolic risks are clozapine and olanzapine, while the ones associated with moderate metabolic risk are risperidone, paliperidone, quetiapine, and iloperidone. The ones associated with low risk are ziprasidone, aripiprazole, lurasidone, iloperidone, and escitalopram, while the metabolic risk of brexpiprazole and cariprazine are unknown. The metabolic highway begins with increased appetite and weight gain and progresses slowly to obesity, insulin resistance, and dyslipidemia, with increased fasting triglyceride levels. Ultimately, hyperinsulinemia leads to beta cell failure, which causes prediabetes and then finally diabetes. Once diabetes is established, risk of cardiovascular events is further increased. So what can be done to counter this? First, increased appetite can lead to elevated BMI and ultimately obesity. Therefore, weight and body mass index should be monitored. Second, insulin resistance can be detected by measuring fasting plasma triglyceride levels. Finally, atypical antipsychotics are known to cause sudden onset diabetic ketoacidosis, also known as hyperglycemic and hyperosmolar syndrome, by unknown mechanism, possibly by the blockade of M3 cholinergic receptors. This can be detected by informing patient of the symptoms of diabetic ketoacidosis and by measuring fasting glucose levels. Thus, the monitoring toolkit should include items for tracking 4 major parameters: weight, body mass index, fasting triglycerides, fasting glucose, and blood pressure. As stated before, the receptors associated with increased weight are H1 and 5-HT2C. Thus, the cardiometabolic complications associated with agents that have both potent antihistaminic properties as well as 5-HT2C antagonistic properties, and the examples being clozapine, olanzapine, quetiapine, and the antidepressant mirtazapine. There is an acute receptor-mediated action of these drugs on insulin regulation. In this hypothesized mechanism, the antipsychotics bind to a so-called receptor X at adipose tissue, liver, and skeletal muscles to cause insulin resistance.